Well, thank you for the invitation, Anna, to talk about care of adults with leukodystrophy. This is an ongoing learning process for me and happy to share, and I've learned from many of you here, so I'm happy to take your input. I already showed you the slide, so this time I'm going to tell you about, that's actually myelin in the cortex. We're going to talk about white matter diseases, but there's lots of myelin in the cortex, and that's what I study outside of this hat and my other hat about replacing it with remyelination strategies. Okay, so today, this round, we're talking about the introduction to the basic terms of what could be diagnosed in the adult clinic, how we do that. And actually, I'll just say that this clinic started as an undiagnosed white matter disorders clinic, and now it's the adult neurogenetics white matter clinic because there's obviously lots of longitudinal care. And I'll talk about the management strategies and symptomatic treatment longitudinal care as much as I know, and then some future directions. So how did I get into this? As an adult neurologist, my PhD was on studying a leukodystrophy that was caused by mutations in connexin 47, otherwise known as Palacios-Merzbacher-like disease, and trying to look to see how astrocytes and oligodendrocytes communicate with each other. Then I did a neuroimmunology MS fellowship, where a case conference every week, there was a small subset of people that just didn't reach a diagnosis in the neuroimmunology evaluation. They didn't have MS or NMO or MOG or infections or a systemic inflammatory disorder. And at some point it was like, what, isn't there another diagnostic step to do? And I had not learned how to do genetic testing in residency and wondered if we could do it in adults. So I was able to work with very generous mentors like Dr. Fatimi, Dr. Vanderver, and Dr. Blackstone when he was down at the NIH to see what disorders could I find by doing genetic testing in adults. And so they would be the leukodystrophies, or the inherited disorders that affect non-neuronal cells or glial cells, the complex HSPs, which is the variant that I had studied actually as part of my PhD thesis for PMLD, and then the more broad term genetic leukoencephalopathy, which sort of doesn't tell you what the cause is, but affects the white matter. And so kind of going into this, I sort of categorize, like, what could I find, right? Basically a bunch of things that I'd never necessarily heard of or seen before. And they're the disorders that typically present in adulthood, and they're just listed here. I'm not going to say all of them, but they typically present in adulthood. And then there's disorders that can present in adulthood. They're more age span disorders. And I'm telling you things that you already know, but this was sort of the setup for what could I be seeing. And at this point, 6 years in, I've seen all of these except for 2. So it's this list was accurate. And then what I've learned from my stroke colleagues is that a lot of adults with white matter disease end up through the stroke clinic. And so there are these inherited vasculopathies, and typically Notch 3 testing is sent and the testing ends there. But as many of you know already, there's many other genes that can cause what appears to be a vasculopathy. And actually, there's a lot of other types of genetic leukoencephalopathies that have diffusion restriction, which is the classic finding of a stroke, but actually is indicating a genetic disorder. So I'm not going to go into the details of what distinguishes us. A lot of these slides are what I use when I give grand rounds to different neurology departments about how to do this. And this slide is just meant to say there are features that do not distinguish whether this is genetic or acquired, right? If you have progressive motor symptoms, bladder, bowel, sexual dysfunction, cognitive impairment, and spasticity, it could be acquired or genetic in adults. You can have bilateral and progressive white matter lesions of a variety of patterns, and it could be genetic or acquired. There are, on history, on presentation, and neurologic exam, there are specific features unique to disorders. I'm not going to go into all the details here, but these are just a list of some of them that might come up in your discussion. And then there's features on imaging that can give you some clues. So for example, if there's cysts and cavitations, even I can recognize that pattern for LCC, but for most of these, there's not such a clear pattern. Something like persistent diffusion restriction and persistent enhancement are sort of really big red flags that this is not your acquired disorders. So when I started, I basically just asked my colleagues to send me people with bilateral white matter abnormalities and clinical features atypical for MS, headache, or vascular disease, or they have a family history of one of these disorders. And they'd already had an extensive workup. And so I started in November of 2018. So you can see there was a trickle. And and I also started by having this just once a month. I only see people a half day a week. Otherwise, I work in the lab. So this was 2 clinics in 2018, and then I was seeing them monthly, and then I realized that there was more and more referrals. So I actually most of my new patients in my weekly clinics are neurogenetics. And it turns out when you've declared yourself an adult leukodystrophy clinic, people that have already been diagnosed find their way to you from all over the place. And so I've learned what L2-hydroxyglutaric aciduria is as a result. It's not diagnosed in my clinic, but has ongoing longitudinal management in adults, as well as some of the other disorders that we've now also diagnosed. So I have experience with that. And then as part of my workup, I send markers for rare acquired disorders like NMO and MOG. So I have actually diagnosed those because of this workup. Sometimes people seem to have more of a toxic leukoencephalopathy, which is a bit of a diagnosis of exclusion. And so we weren't able to exclude it based on the negative testing, or this like atypical multiple sclerosis diagnosis that we can't drop off because our testing was not definitive. And so as a side note, we have this growing cohort of these atypical presentations of MS in this clinic. I'm an MS specialist, so this is not surprising that I have this cohort. This is work I've done here who's a resident, Leah Zaraf, who's now a fellow at UCSF, but has looked at this increasingly larger cohort of atypical MS that most of them, oh, I put my little box around the wrong place. It's mostly primary progressive MS. 2/3 of them are on a disease-modifying therapy for MS, but they don't actually fit the criteria, is the summary. We'll see how it goes with the new criteria that have come out. And there's a paper that just came out last month about genetic disease misdiagnosis MS. So testing is being sent all over the world, and we're learning a lot more about what the overlap is and how to distinguish it. So this very simple diagram explains how we go about the diagnosis. I'm just kidding, it's not simple. But the top row is basically what we do in MS clinic, where if it looks like MS and it smells like MS, we're gonna treat them that way. But if there's any of these red flags, this left column is really the pediatric leukodystrophy clinic. I learned a lot from Adeline Vanderver about finding patterns. I don't get patterns. Pediatric clinic finds patterns and can, narrow down the list of genes. The adult presentation is highly variable, so we have to take a very broad approach for the most part. So which specialties refer patients to the adult white matter neurogenetics clinic? The summary is all of them in neurology. I also have thrown in social media. We've diagnosed people that have been sent as a call out on a women neurology group. What is this? And have made their way to Penn to figure it out. So, it's more. I think the genetic disorders do not care about our neurologic specialty is all I've learned from this. I see people in clinic with a genetic counselor. We heard from the KKI group, which I would love to be able to build a clinic like this. But I do have a genetic counselor with me in clinic. They're not reimbursed by insurance. Arian, who I work with now, I started with Tanya Bardakjian. They are paid for their effort through the MS division, actually, to work with me. Each visit is in collaboration, and this is for the patient and family counseling, discussion of the risks of genetic discrimination, family tree, arranging for trio testing, if we can get it, and insurance approval. And so we meet once a week before every clinic to decide based on what we have already about every person that's coming to see us. Does it make sense to do targeted gene testing, next generation panel that's appropriate to the phenotype, or whole exome or whole genome? And this is all clinical-based testing. And so when we come up with a strategy, we're going for what's the most comprehensive and cost-effective test. So if there's a family history, we go for the targeted gene testing. But if not, we discuss all of the options for a panel that could be covered by insurance. The strategy for this changes over time. When I give this talk at Grand Rounds, I get through my whole thing, and then at the end, the first question is, so which test should I send? And I think, as you know here, there's no one answer to that question. Some people do not want to do the broad-based testing. Some people in the clinic want to go get life insurance and disability insurance before sending the testing, so it's really important to have that conversation. Some people have seen 7 other neurologists, so they just want to find out already what's going on and don't care about those other things. And so the other thing is that we do get insurance approval for this. We find out about all these loopholes, like there's this one company that does free whole genome sequencing if you have Medicaid. So we send that on everyone we possibly can. And then there's other companies that, very antics. And so who knows how long that will last for, but there used to be sponsored panels for the leukodystrophy panel, so we were sending that on everybody. So it really just depends what's available at any time. And then we're constantly asking ourselves, if the first pass testing is negative or unrevealing, which types of genetic defects did we miss? And honestly, we have been learning about this as we go to fully understand which types we have been missing. And then we do a reanalysis, so we get an exome or genome and have made diagnoses that way. And overall, we've diagnosed about 25% of the adults I've seen. So in addition to that, I do send lab and urine testing. So typically what I send from the serum is listed here. Highlights are the ones that actually corresponded to the diagnosis. I send urine testing. I always send NMO and MOG if it hasn't already been sent. In the CSF, I try to send all of this lab testing, and I will just say as an aside, I think Dr. Fatimi mentioned that you have to find all your care partners that'll work with you. I found the guy in our lab who teaches me how to send all the labs that nobody else knows how to do. And so I can actually get the results on these and get them sent out properly. Everyone that comes to see me gets an OCT. This is because I'm an MS specialist, so we get OCT in all of our patients to look at retinal nerve fiber layer thickness. This can be a clue of neuronal thinning over time and is another biomarker that could potentially be used, and sometimes as a clue if it's bilateral or asymmetric. And then with the neurologic exam, when I don't know what it is yet, I'm typically getting a MoCA, an EDSS, and a timed 25-foot walk. Again, that's an MS measure, and it's really easy to do in my clinic. And once we have a diagnosis, we can tailor some of these more specifically, but this is something that we're just basically getting on everyone. So just to get an idea for what we've diagnosed, perhaps not surprisingly, the highest cohort is X-linked adrenoleukodystrophy and AMN. It's actually half women, half men. Then CSF1R, retinal vasculopathy with cerebral leukoencephalopathy. I see because I collaborate with a rheumatologist, Jonathan Miner, who heads this RVCL center. So I've seen a bunch of people with that. And then adult polyglucosame body disease. And then you can see that I've actually started diagnosing some of these more age span leukodystrophies over time, as well as many different types of HSPs. We have a bunch of N equals 1, where I get the test result back and I look on gene reviews, find out what this is. And then because we're sending broad-based testing, we have non-leukoencephalopathy diagnoses like Canvas and FTD and KIF1A and tuberous sclerosis and HNPP and APP duplications. And I don't know why, but collecting them. So adding in some glia discussion because they're my favorite, and this is happening in Gliadelphia. So this is just sort of my schematic that I originally made actually for MS, because there's the interface of the immune system and the central nervous system for how that disorder is started and happens over time. And I actually could use the same thing to add to define a cell-based cause of inherited white matter disorders, and they could be due to disruptions in the astrocytes, the microglia, like I talked about this morning with ALSP, the oligodendrocytopathies, leukoaxonopathies, and then the leukovasculopathies. And then I put it here because I think most of mine go into every other category but the oligodendrocytopathies, which I think is sort of the classic finding of a leukodystrophy clinic. In the adult world, I think maybe we're getting all the other ones. So I've learned a few things in this time. It works to have clinic a half day a week because it's about 3% of the referrals to Penn Neurology Genetics. That there's a standard approach that we use in our neurogenetics group for all adults. to get them ready for for diagnosis and management and ready for trials. That there's disparities for who's referred for genetic testing, but not for identifying a genetic diagnosis. And the leukodystrophies were actually not included in this paper because I didn't have enough people yet at the time that they did the study. So I'll be looking at this again. But because of this finding, we actually have an EPIC, this pilot, to look through people's charts and pop up to people's PCPs if somebody might be a good candidate for genetic testing. So we'll see if we can apply that to the white matter disorders going forward. And then the common features of adult leukodystrophy presentation are that there's nothing the same. They're very heterogeneous, even for the same disorder in the same family. And then the white matter lesions don't follow a pattern that I can identify, but there can be unique features. And there's typically diagnostic delays and misdiagnoses. I'm never the first neurologist somebody has seen for what they're coming in for. So everybody who comes to see me is offered participation in the Global Leukodystrophy Initiative and to be part of the Myelin Disorders Biorepository Project. I consented my 200th patient this week. So basically anybody that agrees to be part of that their clinical data and imaging are de-identified and we process blood samples, which has led to additional studies that we do. I didn't have time to mention it this morning that we're doing for ALSP and applying to other disorders. That there's multiple glial sites. Obviously, many of you here are part of that and that there are several adult sites now. So we end the diagnostic odyssey. What's next? So these are sort of the principles that I share at Grand Rounds to say that you have a diagnosis and there is actually a next step to do once you've made it that far. So you need genetic counseling for the diagnosis and implications for family members. We, even on the most simple basis, we provide a letter explaining what it is so that people can share it with their family members. This is taken in a variety of ways by family members and depends on the disease. I've had people need to not come back for 9 months, even though we had a treatment trial at our site, because they just had to adjust to actually finding a genetic disorder that they were, even despite all of the previous discussions, were not expecting. So once we have this, I look to the published guidance and consensus guidelines to see if there's available disease modifying or symptomatic treatment. We start appropriate baseline and surveillance testing. We start disorder appropriate symptomatic treatment, refer to the appropriate foundation if available. And then if there's a center with expertise, I will send them there. And then obviously look on clinicaltrials.gov for clinical trials. So my first step, and again, take any input, and then I ask all of you if you hear from me, is I look on gene reviews for the gene to learn about it. I look on OMIM if it's not there, or reviews. We look to the foundations, obviously Hunter's Hope, United Leukodystrophy Foundation, or a disorder-specific advocacy group. For example, for my very first clinic, I diagnosed adult polyglucosan body disease. I reached out to the research foundation. I got a call back from Edwin Kolodny asking me how I found one of these patients. And so we had a nice discussion about that. I contacted them after the second patient, and they put me on their advisory board. So I work with them a lot. Then obviously there's a lot of research opportunities. These are the ones I just told you about that I'm involved in. And then there is actually this effort called White Matter Rounds. It's organized by Roberta Lapiana out of McGill, and it's a monthly case conference for adults with unknown white matter disorders or for management strategies for what to do with complicated cases that everyone is invited to become involved with. You can go to the website and sign up. All right, so when I look and I don't find consensus guidelines, you have to make them. And so I've been lucky to be part of a few of these efforts. Seeing a handful of these patients apparently makes you a world expert. And so, you take that with a grain of salt, but can offer what I can do on the adult side and from our experience. And so we've done that for APBD, contributed to MLD, and then working with many of you here, we actually took the next step to do a practical approach for the adult neurologist for ALD and AMN. And so there was already consensus guidelines for what to do for ALD and AMN, but you can see the chart stops at 10 and 12, right? And I don't think an adult neurologist will look at this paper and think that that's for me. So we put it in the title. Sorry, this adult neurologic care, and then basically went through the principles of once you have the diagnosis, what you have to do for baseline and longitudinal care, including doing endocrine screening. Okay. So you have to find care partners for adult leukodystrophy care. This is easier said than done. So for example, which type of neurologist should people see? Like I said, I'm a neuroimmunology MS trained specialist. I think I'm actually in a pretty good place to take care of this group of people because many of the symptoms are the same types of symptoms that we see in MS and some of these autoimmune inflammatory disorders. So we at least have that, but certainly not all of them. However, something like HSP is managed by neuromuscular movement disorder, sometimes myelopathy MS clinics, and it's actually not clear who should be taking care of them. So these are something that we have to figure out over time. We obviously need a primary care doctor. I've not been able to find this. There's a version over at CHOP that I've, worked with a complex care pediatrician. I've not found the equivalent on the adult side. I'm working on that to try to keep people out of the hospital. Obviously, genetic counselor. I think a psychiatrist might be hard for everybody to find, but having a therapist or psychologist, we need to have neuropsychologists to evaluate people to see if they should be working, or if they can. Sometimes that evaluation will say this person should not be driving anymore, and it really depends on the disorder. And that is a very difficult hurdle to overcome for someone who has been doing this for a very long time. Urologist, physiatrist who can help coordinate the physical and occupational therapy care. I'm just going to say as a note here that I have been scoring PMDs for motor scores, and I am jealous of the support systems that you have in a pediatric neurology clinic. As I read through all of these charts, there are things that we don't have available in the adult world for support for mobility. And sort of communication device and that sort of thing that we can learn from you. So going forward, hoping to do that. We need a speech therapist, a social worker, a nurse practitioner, pharmacists. We actually have a lot of pharmacists in our MS clinic, so that is fairly easy to do. Endocrinologists and nutritionists. We actually can't really get access to nutritionists in adult care unless you have diabetes, is what I found. So we have to try to be creative. And so I operate within this comprehensive care MS center and the neurogenetics division at Penn. So I'm joined by an MS fellow. So I'm training somebody and learning at the same time. And I told you Dr. Ninovich told me that she wants to do this going forward. So this is great. I'll do it person by year. But we have access to a social worker, pharmacist, neuropsychologist, and a genetic counselor through this effort. But that means we don't have the rest of the people in clinic. And that is a very challenging thing to do in the adult clinic. And so that means I have to refer to people and I'm limited by insurance. And I think the biggest factor that we're limited by is, somebody's going back to where they live locally, they're going to go to PTOT and they're going to say, we don't treat that. You're not getting any better, so your PT is done. And I know we've all heard that. So some of the strategies that we've come up with is I'll tell people and I'll give them a list of MS trained or physical therapists that have MS certificates, if some of their symptoms overlap with what we see in MS, so that at least there's a guess in, or to say like go to an ataxia trained a physical therapist. And so to basically give the person in front of me the terms to help teach other people what they can actually help with without being intimidated by the name of the rare disorder. This whole multidisciplinary clinic can be very challenging for patients transitioning to adult care. I put this as a bullet point. It's his own talk. But there are transition teams. We do this on the MS side as well for the rare kids that are transitioning to the adult clinic. It's hard no matter what it is, but I'm able to work with teams at CHOP that are the transition teams who ahead of time can find all of the care partners, and I will offer suggestions for people who I've already found so it can be set up ahead of time before they leave the children's hospital. But sometimes insurance prevents all of those things from happening, so we end up having to be really creative. All right, so longitudinal and symptomatic management. I know you all know of many of these things here already, so I don't need to tell you the specifics of it. I bolded what I think I know how to do from the MS clinic. And then what's not bolded, I think, are what an MS trained physician feels less comfortable with. And so sometimes if there's the first line treatment that we would think of to try doesn't work, I have to send to a specialist who, like a movement disorder specialist or a peripheral neuropathy or an epilepsy specialist to get help with that, because I just don't have enough experience or know what the latest options are, for example. But I do, sort of do this route for the people that have the rare leukodystrophies that come to me, and I'll give them a bridge medication for when they get a cold so that they don't have increase in seizures, which we don't often do in adult neurology, but for these guys, I do. And then, I wanted to say screening for endocrine, cardiac, lung issues, tumor development, bone and teeth abnormalities. I mean, this depends on the disorder. So I think most neurologists do not necessarily, adult neurologists feel comfortable doing this. I think the MS neurologist actually does this all the time. We have 25 DMTs that we give out between MS and other rare neuroinflammatory diseases, and we are screening safety labs all the time. And so it's actually not that different from what we're already doing. So they just have to sort of spin it that way. So outstanding questions for the adult neurology clinic. Are genetic white matter disorders underdiagnosed in adults? I think the answer is yes. I think we're still working on narrowing down who should get tested and which clinical genetic test should be sent. Been working in many areas to develop educational content. There's an ANA highlights on neurogenetics. I did a AN podcast on genetic leukodystrophies mimicking CNS inflammation. I do a lot of grand rounds. I teach the MS fellows at a national lecture series that's done for all the MS fellows on this. So hopefully the word is getting out, but happy to take input on how else we can do this. One of the main questions is, how do we end the diagnostic odyssey for those with unresolved testing, especially the VUSs? Ideally, we'd like to obtain definitive genetic testing like whole genome on everyone. That's not accessible to everyone yet, so we're working on it. And then we need to figure out, we actually still do ongoing longitudinal and symptomatic management, even if we haven't found a diagnosis. And then one of the things that I mentioned, I think in the Q&A before, is can we incorporate clinical trial outcomes into the standard clinic assessments so that this will make retrospective chart studies easier. But and to do this, we have make an EHR template, incorporate standardized motor and cognitive measures, standardized frequency of lab testing like serum, NFL, and GFAP. And then surveillance MRIs with consensus-based sequences, trying to work in many efforts to help get that out there. So the specific challenges in the adult clinic are obtaining the genetic diagnosis, building a multidisciplinary team, and getting access to treatment. For example, I can identify people with cerebral ALD, but who is going to do their HSCT, right? I actually have not figured that out yet. And so this is an ongoing challenge itself. So it is possible to have a multidisciplinary clinic that incorporates genetic counseling into metabolic and neurogenetic evaluation of undiagnosed white matter disorders, and we can identify known adult onset leukodystrophies. For the known disorders, there's longitudinal management that's defined or in the process of being defined, and there's many patient advocacy groups that can support the effort for both the clinician and the patient family. And often I send the newly diagnosed people off to those conferences to go and learn about it and then tell me what to do. And in some cases, I send them to you guys to tell me what to do so that we're doing the right thing. There are many opportunities for research, as you all know, and the care involves a multidisciplinary approach that can be challenging to build, but it's possible with some creativity. And it takes a village to do this, honestly. So this is in the setting of my lab. Christine sets up all of the consents and the lab processing that we do on those 200 patients. And the Barrow lab supports this and is developing assays with us for peripheral monocytes. The MS division is sort of my infrastructure that I work in to make this happen, along with our fellows, and this is Laura here with Sisters Hope Foundation. Our neurogenetics group and the Penn Center for Therapeutics is actually already building a gene therapy program, so we have that in place for any of these disorders that end up having a potential gene therapy intervention. And obviously, Aaron plays a huge role here in everything that we do. So with that, thank you.